But actually, you want to have direct comparison. Is that surgery cheaper or medical treatments or whatever cheaper? Now, this is probably the quite long time publication from United States. This offers input the data from his center and use a reference population from the United Kingdom, about more than 500 patients with obese type 2 diabetes and only single operative procedures, bypass. Duration of diabetes quite long, which now we advise less than 5 years. And the result is surgery has a more significant improvement in quality of life by measuring QALY. QALY means this cost for improvement of one single unit of quality of life is cheaper than conventional treatment. Okay. Now, Hong Kong, haven't calculated, the answer not yet come out, but it's in the progress. We have already gained a research funds now in the process, but unfortunately, I'm not able to give you an answer. But this is another single paper from mainland China. He also do a randomized control trial comparing sleeve, medication, and bypass. He found the costs of obviously is more expensive than medication use. A follow-up duration of 2 years. This 2 years seems too short, but the very important information or implications is if 2 years you calculate the improvement in QALY, that means 1 unit of improvement, actually sleeve gastrectomy and bypass is cheaper than your medication in 2 years follow-up. So that means medication is cheap, but then it doesn't make that significant improvement in healthcare, quality of healthcare. And if the money comes back in 2 years after your investment, that is significant impact, right? If you really want to look at the exact number, you compare this surgical procedure with colon cancer. If you get an obesity-related cancer, you compare the surgical procedure, and myocardial infarction is more expensive, and strokes. So all outweighs or more expensive than the surgical procedure alone. But this is just a reference for, mind you, because it's just the surgical procedure itself not yet take into account, as I said, the recurrence, the relapse, the complication, whatever, okay? So this is just a reference. More obesity patients gain more benefit if you subject them to have metabolic surgery. As you increased, that the BMI is higher, the cost per incremental QALY is lower. That means you more, because higher BMIs tend to have more complications, comorbidity. If you offer same price surgery, the benefit will be higher. So the conceptually is the more severe is your obesity, you offer same price of surgery, then you get more benefit. That means you're cheaper. So the more expensive than you are, then you're more suggestive to have surgery. And now we know surgical procedure in the international guidelines already stratified different BMI should have different intervention. We have protocol on that. And if you really want to take a number of BMI cut-off point, this offer actually get the number of BMI 30 to 35 instead of in the older days NIH recommendation or guideline. BMI should be 35 with comorbidity or 40 without comorbidity surgery. But then this is scientific evidence that it become more cost effective when you subject the patient to have 30, lower the BMI cutoff BMI value to 30 or 35. So another factor is if you select not only patient, but then when you go to high volume center instead of go to low volume center, your cost will be cheaper because high volume center tends to give you lower complication rates, and therefore the high volume center would be more cost effective. So gender, we don't know why, but then seems ladies more beneficial to have better. So to summarize, metabolic surgery for surgically eligible patients, not for those mildly obese, is more cost effective and cost saving. All right, it's more cost saving when you have obesity, comorbidity, or when you have higher BMI, and you should go to a high volume center for metabolic surgery. So that summarizes my talk.